Dr. Ken Zurcher, a PGY4 resident physician at Mayo Clinic, Arizona. For this RSNA case of the week, I will be discussing a case of middle aortic syndrome. Our patient was an 11-year-old male who presented with worsening headache for several months. Vital signs demonstrated severe hypertension, ranging from 180 to 200 systolic. Urgent cardiology workup was performed, with transthoracic echo demonstrating left ventricular hypertrophy and possible descending aortic coarctation. CTA of the chest, abdomen, and pelvis was obtained. Maximum intensity projection sagittal images on the left and axial images on the right demonstrate marked thoracoabdominal aortic stenosis, measuring 3 to 4 millimeters in narrowest diameter. CTA 3D reformats on the left further depict this narrowing. A MIP 3D reconstruction demonstrates prominent compensatory arteriocollateralization of the abdominal wall, including the superior epigastric to inferior epigastric pathway. This patient subsequently underwent aorto-aortic bypass with PTFE grafting extending from the thoracic aorta to infrarenal abdominal aorta, as seen on this CTA 3D reformat. At 3 months follow-up, the patient demonstrated continued refractory hypertension and elevated upper to lower extremity blood pressure gradients related to persistent distal thoracic aortic stenosis. Intraprocedural fluoroscopic images shown here demonstrate stenosis at the proximal aorto-aortic bypass graft anastomosis, which was successfully treated with endovascular stenting. Post-stenting pressure gradients improved from 35 to less than 5 millimeters of mercury. Our final diagnosis in this case is middle aortic syndrome. MAS is a rare acquired or congenital vascular disorder resulting in severe narrowing of the abdominal aorta and/or distal thoracic aorta, and can result in significant morbidity secondary to vascular stenosis of the aorta and its involved branches. Some differential diagnoses to consider include pseudocoarctation of the aorta, which refers to a physical kinking of the aorta, typically of the ligamentum arteriosum. Marfan syndrome patients also present with aortic pathology, however this typically involves aneurysms or dissections. Takayasu's arteritis has been described as a potential factor in the development of MAS and can result in this stenotic appearance, though data remains limited. Traditional aortic coarctation is considered to be of the upper thoracic aorta, in the region of the ligamentum arteriosum, or more proximally. As previously mentioned, MAS is exceedingly rare, with less than 700 cases reported. This accounts for 0.5 to 2% of all cases of pediatric aortic stenosis. Mean age of presentation is approximately 9 years. Patients present with severe upper extremity or renal vascular hypertension, seen in over 87% of patients, or with headache or lower extremity claudication. If untreated, MAS can result in left ventricular hypertrophy, CHF, cardiomegaly, or decreased renal function. The etiology of MAS remains poorly understood, with 64% of cases being idiopathic. In small case series, associations with NF1, Takayasu's arteritis, Williams syndrome, and Alagille syndrome have also been described. Although angiography was previously the gold standard of diagnosis, this has been widely replaced by CTA or MRA if needed. On imaging of MAS, segmental or diffuse narrowing of the abdominal aorta is seen in 97% of cases, with thoracic involvement in the other 3%. The renal arteries, SMA, and celiac arteries can also be involved. Multidisciplinary management of MAS is key. The workup and indications for intervention remain to be standardized, but include risk of renal failure, refractory hypertension, claudication, or intestinal ischemia. In uncomplicated cases, medical management has been shown to be effective in 50% of cases. In the remaining instances, 28% of patients undergo endovascular intervention, such as angioplasty with or without stenting, and 55% of patients undergo surgical management, such as aorto-aortic bypass, reconstruction patch graft, or renal autotransplantation. That concludes my case, and thank you for listening.